Brow ptosis is the downward migration of periorbital soft tissues. This is a common occurrence that steadily increases in individuals who are 50 and older. This condition may pose functional and cosmetic concerns for the patient. Depending on the severity, those affected may complain of issues such as visual field obstruction or an unappealing resting facial aesthetic. Several surgical and non-surgical techniques have been developed to manage this age-related process. One of these procedures is the direct brow lift. Clinicians specializing in facial rejuvenation techniques should thoroughly understand the medical and surgical management of brow ptosis. These techniques can help avoid complications, optimize the results, and better achieve the patient's goals. In this journey, you will gain an in-depth understanding of brow ptosis, its prevalence, and its impact on patients' functional and cosmetic well-being, particularly those who are 50 and older. The focus is on the direct brow lift procedure, exploring its nuances, indications, and potential outcomes. The complexities of patient evaluation, surgical techniques, and postoperative care specific to periorbital aging are discussed. The paper also emphasizes the collaborative nature of addressing periorbital aging through the direct brow lift. The significance of an interprofessional team, including surgeons, nurses, anesthesiologists, and rehabilitation specialists, is emphasized. Collaborative learning experiences are highlighted to enhance competence in patient assessment, preoperative planning, intraoperative execution, and postoperative care. Objectives: implement precise surgical techniques for direct brow lift procedures, demonstrating proficiency in tissue manipulation, fixation methods, and incision placement to achieve desired aesthetic and functional improvements. Screen patients for suitability for a direct brow lift, assessing their medical history, expectations, and potential contraindications, ensuring optimal patient selection. Assess patients for clinical signs of brow ptosis and determine the severity of visual field obstruction or aesthetic concern. Collaborate with interprofessional teams including ophthalmologists, anesthesiologists, and nursing staff for comprehensive preoperative assessment, intraoperative support, and postoperative care coordination. Introduction: the periorbital region, including the eyebrows, upper eyelids, and lower eyelids, undergoes predictable changes during aging. With advancing age, the brow descends relative to the supraorbital rim, often resulting in dermatochalasis. Commonly, this presents as hooding of the lateral eyelids, but, in severe cases, may result in upper visual field obstruction. Other less common causes of brow ptosis include facial paralysis and post-traumatic deformity. Various surgical options exist to reposition the brow, ranging from traditional open techniques to newer endoscopic approaches. Each method has strengths and weaknesses, but no procedure has been proven superior in all clinical scenarios. In recent years, the focus of aesthetic surgery has shifted toward minimally invasive techniques, such as endoscopic brow lifting. However, performing traditional open approaches is still essential for facial surgeons as these techniques offer the highest precision when repositioning the brow. This activity discusses the details of one such open approach, the direct brow lift, and its significance in rejuvenating the upper third of the face. Anatomy and physiology. The upper third of the face exhibits many characteristic signs of aging, including horizontal mid-forehead lines, due to the vertical action of the frontalis muscle. Fullness of the upper lateral eyelid, caused by the descent of the upper facial soft tissues and brow ptosis. Vertical and oblique glabellar lines from the action of the corrugator supercilii and the depressor supercilii muscles. Horizontal glabellar and nasal root lines, due to the action of the procerus muscle. Pertinent anatomic structures. Layers of the forehead. The skin of the brow is thicker than that of the upper eyelid. The thickest part of the brow skin is towards the middle, near the glabella, which is highly sebaceous. Skin with high sebum secretion is more prone to scarring. Therefore, most surgeons attempt to avoid making a direct brow incision in this area whenever feasible. Beneath the skin lies subdermal fat, and beneath that is the muscular layer. The most superficial muscle is the procerus, with the corrugator underneath and the frontalis beneath that. The corrugator is deepest medially, where it originates on the frontal bone, and most superficial laterally, where it inserts into the dermis of the brow. Below the muscle is the periosteum, which adheres to the underlying calvarium. Supratrochlear nerve. This nerve provides sensory innervation to the medial upper eyelid, glabella, and a small portion of the conjunctiva. The supratrochlear nerve courses through the corrugator muscle and is usually located 1 cm medial to the exit point of the supraorbital nerve or 1.7 cm lateral to the midline. Supraorbital nerve. This nerve exits a notch or foramen roughly 2.7 cm lateral to the midline forehead between the mid-pupillary line and the medial limbus. The supraorbital nerve further divides into deep and superficial branches, providing sensory innervation to the frontoparietal and upper eyelid skin, respectively. Frontal branch of cranial nerve 7, the facial nerve. This provides motor innervation to the forehead muscles such as the frontalis, corrugator supercilii, procerus and the upper orbicularis oculi muscle. The path of this nerve may be approximated by the Patangi line, which is drawn from a point 0.5 cm inferior to the tragus to a point 1.5 cm superior to the lateral brow. Ideal brow location and shape. The classical ideal women's brow position have been described as the brow forming an arch, with its highest point located above the supraorbital rim, between the lateral limbus and the lateral canthus. The eyebrow should possess a defined and thicker appearance in the medial region, aligning with or just above the supraorbital rim. The brow should ascend above the rim, moving laterally and gradually tapering for a harmonious aesthetic appearance. In men, the ideal brow is relatively flat and lies at the level of the supraorbital rim. Indications for brow lift surgery are as follows. Visual field obstruction where excess skin can obstruct vision, necessitating surgical intervention. Pseudoblepharotosis where excess upper eyelid skin prolapses over the lash line, but there are no pathology of the eyelid musculature or levator aponeurosis present. Most often this is due to significant dermatochalasis that is exacerbated by brow ptosis. Brow ptosis where there is a natural drooping of the brow creating a fatigued or aged appearance. Facial nerve paralysis causing a loss of muscle tone which can lead to asymmetry in the brow area. Presence of brow asymmetry, often due to unilateral or asymmetric blepharotosis. Deep forehead wrinkles and prominent lines which contributes to an older appearance. Glabellar lines or vertical lines between the eyebrows which convey an unintended expression of anger or worry. And finally aesthetic concerns where patients seek surgery to address concerns about appearance of looking tired or angry. Clinical situations favoring a direct brow lift approach are patients with lack of forehead ritids, unilateral facial paralysis which require precise control of the elevation of each brow individually, convex forehead where the craniofacial skeleton limits the endoscopic approach, patient with receding hairline or baldness, patients with heavy eyebrows or prior eyebrow scar and finally patient's preference. The direct brow lift is increasingly used as a reconstructive technique and is less commonly performed in the cosmetic setting. In contrast, there are multiple indications for other brow lift approaches. Other brow lift approaches include endoscopic brow lift, which consists of multiple small incisions made within the frontal and temporal hairlines to permit the insertion of the endoscope and surgical instruments. This technique provides a minimally invasive approach with a theoretically decreased risk of injury to neurovascular structures and shorter healing times. It is not suitable for patients with receding hairlines or convex foreheads, which may restrict endoscopic visualization. It requires fixation, typically with absorbable materials such as bioabsorbable anchors or sutures, to reposition and stabilize the forehead's soft tissues. It only provides moderate brow elevation. The hairline brow lift technique involves an incision either within, trichophytic, or just in front, pretricheal, of the hairline. This permits bilateral elevation of the periorbital soft tissues and it is useful in patients with elongated foreheads because this technique may be used to lower the patient's hairline. It may also be combined with a hairline advancement in the same operation. Coronal brow lift technique. Incision are made several centimeters behind the hairline. Incision is completely hidden within the hair. This technique should be avoided in patients with elongated foreheads because this technique will elevate the patient's existing hairline. It is also important to avoid this procedure in bald patients, as this may leave an unsightly scar. Mid-forehead brow lift technique. Incision is placed in the middle of the forehead within an existing horizontal retid. This permits bilateral brow repositioning with a single incision. This is best suited for men with a receding hairline or baldness and deep forehead ritids. Multiple ritids can also be excised within the planned incision. However, this technique is less commonly performed due to visible scarring, even if the scar is aligned appropriately within a forehead ritid. Contraindications to brow lift surgery. The contraindications to any brow lift surgery includes the following: patients with suspected body dysmorphic disorder, previous history of blepharoplasty due to the increased risk of lagophthalmos after the brow lift procedure, previous history of dry eye syndrome or decreased tears production which may worsen the dryness and also increase risk of lagophthalmos. Specific contraindications to the direct brow lift approach. The contraindications to the direct brow lift approach include patient's unwillingness to accept a potentially visible facial scar, patient with thin eyebrows, anatomy or expectations that are better suited for another surgical approach. These are some of the equipments needed for performing a direct brow lift procedure. Preoperative equipment includes a surgical marker, local anesthetic with a hypodermic needle and syringe, surgical cleansing solution, eye protection such as a corneal shield or eye taping. Intraoperative equipments includes a 15-blade scalpel, caliper forceps such as the Adson-Brown forceps, tissue scissors such as the K-blepharoplasty or strabismus scissors, needle driver such as Halsey, suture scissors such as Mayo or Iris scissors, electrocautery device, and sutures based on the surgeon's preference. Postoperative external wound dressing are based on surgeon preference, and some practitioners will provide a course of antibiotic ointment application. All potential surgical patients should undergo a preoperative evaluation by a medical professional to assess the surgical risk and optimize for general anesthesia, if required. A thorough physical examination should be conducted with the patient in an upright position, focusing on brow position, visual fields, rhytids, scars, and facial nerve function. To accurately assess the brow position at rest, the patient should be instructed to close their eyes and fully relax the forehead, as many individuals with significant brow ptosis involuntarily contract the frontalis muscle when their eyes are open. Preoperative photographs are essential and should include frontal views in repose and with eyebrows elevated, as well as profile views in repose. If a concurrent blepharoplasty is planned, additional photographic views should be obtained. Patients should be counseled thoroughly about the procedure's risks, benefits, and alternatives. Specific risks associated with a brow lift include improper brow position or asymmetry, incomplete eye closure, dry eyes, unsightly scarring, the need for revision surgery, alopecia, numbness, and facial nerve injury. Common surgical risks such as pain, bleeding, and infection should also be discussed. Setting realistic expectations is critical. Patients should be informed that while direct brow lifting and other facial rejuvenation procedures can create a more youthful appearance, the aging process will continue to occur. For instance, if the procedure offers a 10-year rejuvenation to a 60-year-old patient, the patient may appear 50 shortly after surgery, but will look 60 again by age 70, and 70 by the age of 80. Candidates for simultaneous facial rejuvenation procedures, such as blepharoplasty, fat transfer, or laser resurfacing, should be identified and counseled appropriately. Important anatomical landmarks must be carefully noted, including the supraorbital rim, supraorbital and supratrochlear neurovascular bundles, temporal line, sentinel vein, corrugator supercilii and procerus muscles, Patangi line, hairline position, and the desired brow shape and position. While general anesthesia may be used, it is not mandatory for all procedures. Muscle paralytics are typically avoided to facilitate intraoperative facial nerve monitoring if desired. A single preoperative dose of intravenous antibiotics targeting skin flora may be administered. The procedure is usually performed with the patient in the supine position. Skin marking begins with a fusiform beveled incision within the superior row of eyebrow hair. The upper incision is designed to match the desired amount of brow elevation, with most of the lift focused laterally to restore the natural brow contour. Surgical technique. Successful completion of the direct brow lift requires the surgeon to have an excellent soft tissue handling techniques and a thorough understanding of facial anatomy. The routine steps in performing a direct brow lift are as follow. The patient is prepared for the surgical procedure once the proper preoperative checklist has been completed. The patient is positioned and draped in a standard sterile fashion. A safety checklist is followed, and the surgical timeout is observed. The planned amount of skin to be resected is verified and compared to the preoperative markings. Local anesthesia of 1% lidocaine with 1 in a 100,000 adrenaline with a maximum volume of 7 mg per kilogram of lidocaine is injected into the planned surgical site. If the patient is undergoing the procedure under local anesthetic, adding 8.4% bicarbonate to the local anesthetic around 10% of the volume of the lidocaine will buffer the local anesthetic and reduce discomfort during injection. A 15-blade scalpel with a slightly beveled incision, allowing the final closure to naturally evert the skin edges. One should bevel the blade toward the hair follicle near the eyebrow to preserve the brow hairline. The skin and underlying soft tissue are resected while avoiding injury to underlying neurovascular structures and muscles such as the frontalis and orbicularis oculi. The ptotic frontalis and orbicularis oculi muscles may be suspended to a more youthful position by superiorly anchoring them to the forehead periosteum. If prominent rhytids of the corrugator and procerus muscles need to be addressed, medial dissection may allow for sectioning of these muscles. Hemostasis is achieved using pressure and limited electrocautery to avoid injury to the supraorbital and supratrochlear nerves. The deep layer of the wound is closed using absorbable sutures, commonly 4 or 5 vicryl. The skin may then be closed using a subcuticular or a running cutaneous stitch using 5 or 6 plain gut or praline sutures. A dressing over the wound is placed over the wound based on the surgeon's preference. Complications of direct brow lift, although rare, may include wound infections, hematoma, brow asymmetry, forehead numbness, injury to the frontal branch of the facial nerve, unsightly scar formation, alopecia of the eyebrow, revision surgery, overcorrection, and eye dryness. The meticulous surgical technique will minimize the appearance of the inevitable postoperative scar, particularly if the excision does not extend into the sebaceous skin of the glabella. The direct brow lift represents an essential tool in the armamentarium of the aesthetic and reconstructive facial surgeon. Direct brow lifting provides precise repositioning of an asymmetric or ptotic brow, making it applicable in facial aging and facial paralysis. The surgeon offering this technique should also be well versed in the other approaches to brow lifting to advise and select the best plan for the individual patient. The outcomes can be very satisfactory in the hands of a knowledgeable and experienced surgeon. A comprehensive approach is imperative to enhance patient-centered care, improve outcomes, ensure patient safety, and optimize team performance during a direct brow lift procedure. Initially, meticulous skills are required to identify risk factors and conduct a thorough medical assessment. This involves collaboration among healthcare professionals, including a surgeon well versed in facial aesthetics, medical optimization for anesthesia, and an ophthalmologist or optometrist evaluation to address potential visual concerns. Responsibility falls on a specialized preoperative, operative, and postoperative nurse who monitors patients and aids in care coordination and patient education. An interprofessional team comprising a facial surgeon, an anesthesia provider, and an operative nurse should conduct the procedure to achieve optimal outcomes. Subsequent close follow-up is crucial to monitor for potential complications, and patients should receive counseling on wound care and activity levels. Such interprofessional care is paramount in achieving optimal results in facial reconstructive surgeries, such as direct brow lifting, by embodying the principles of skill, strategy, ethics, responsibility, interprofessional communication, and care coordination. Recovery following direct brow lift surgery varies for each patient due to their individual functional and nutritional status. Meticulous local wound care ensures a healthy and clean healing environment. Blood thinners may be restarted on postoperative day 1. The patient should be counseled to avoid heavy lifting or straining until follow-up, to minimize edema and ecchymosis. When proper sterile technique is employed, postoperative antibiotics are not necessary. If used, permanent sutures for skin closure should be removed within 5 to 7 days, depending on the amount of wound tension present. Following surgery, the patient is typically seen regularly in the outpatient clinic until satisfactory healing has occurred. Close follow-up will help identify any acute postoperative complications. Prompt identification and appropriate management will ensure optimal outcomes.